Good evening, everyone. I'll be presenting my paper on Davidoff Masson syndrome, rare presentation of cerebral hemiatrophy. My name is Dr. Shivendra Mishra, junior resident. My co-author is Dr. Mahavir Yadav, senior resident, Kalinga Institute of Medical Sciences, Bhubaneswar. Aims and objective. Awareness of imaging features of Davidoff Masson syndrome is essential for accurate diagnosis and timely management. Patients with Davidoff Masson syndrome typically presents with refractory seizures, and initial treatment should focus on seizure control using appropriate anticonvulsants. For children with intractable, disabling seizures and hemiplegia, hemispherectomy remains the treatment of choice, with reported success rate of up to 85% in carefully selected cases. However, since hemispherectomy is not available in many urban tertiary care centers, and even less so in rural settings, it is particularly important for neurologists and pediatricians in rural areas to recognize the condition early using appropriate neuroimaging, CT or MRI. In such cases, management should emphasize optimal seizures control with appropriate drugs, regular revision of medical dosages, and domiciliary physiotherapy to improve functional outcomes. Material and methods. MRI was performed using a 1.5 Tesla system for data acquisition. This was a retrospective study in which the clinical records and MRI findings of the patients were reviewed. The procedure, purpose, and relevance of the study were explained to the patients and or their relatives, and informed consent was obtained prior to inclusion. Introduction. Davidoff Masson syndrome is a rare cause of cerebral hemiatrophy reported in adults, adolescents, and children. The condition has been documented in both sexes with a male predominance and a higher frequency of left hemispheric involvement. Davidoff Masson syndrome typically develops in early life as a consequence of brain injury or intrauterine cerebral insult. Clinical features commonly include recurrent seizures, facial asymmetry, contralateral hemiplegia, or hemiparesis. Additional features may involve intellectual disability or learning difficulties, speech and language disorders. Characteristic imaging findings on CT and MRI include cerebral hemiatrophy, ipsilateral lateral ventricular dilatation, compensatory calvarial thickening, ipsilateral paranasal sinus hypernematization. Case 1 is a 20-year-old male presented with repeated episodes of uncontrolled seizures. He had a history of childhood onset seizures which were initially controlled with medication, along with delayed developmental milestones and intellectual disability. On examination, facial asymmetry was noted. CT brain images shows left hemicerebral atrophy. There is ipsilateral lateral ventricle ex vacuo dilatation, minimal midline shift of falx cerebri to ipsilateral side at the coronary data and Sylvian Fisher level. CT brain images shows compensatory ipsilateral calvarial hypertrophy, ipsilateral frontal sinus hypernematization, and ipsilateral mastoid air cells hypernematization. 27-year-old male presented with a generalized tonic-clonic seizures and right-sided hemiparesis. The patient had a history of right-sided hemiparesis since childhood, which had progressively worsened over time. He experienced his first seizure episode at age of 6 years, which was initially controlled with medication. He also had a history of delayed developmental milestones and intellectual disability. This is the case 2. The MRI brain images shows left hemicerebral atrophy. The FLAIR images shows thin rim of hyperintense signal, that is encephalomalacia and gliosis, causing ipsilateral lateral ventricle ex vacuo dilatation, and minimal midline shift of falx cerebri to ipsilateral side. MRI brain images shows compensatory ipsilateral calvarial hypertrophy, ipsilateral frontal sphenoid sinuses hypernematization, and ipsilateral mastoid air cells hypernematization respectively. Case 3 is a 25-year-old female presented with uncontrolled seizures. She had a history of childhood onset seizures which were initially controlled with medication along with learning difficulties and slurred speech. On examination, facial asymmetry was observed. CT brain images shows left hemicerebral atrophy. There is ipsilateral lateral ventricle ex vacuo dilatation and minimal midline shift of falx cerebri to ipsilateral side. CT brain images shows compensatory ipsilateral calvarial hypertrophy, ipsilateral frontal sphenoid sinus hyperpneumatization, and ipsilateral mastoid air cells hyperpneumatization, respectively. Discussion: children with hemiplegia are potential candidates for hemispherectomy, which has a reported success rate of up to 85%. In cases with late onset presentation, management primarily involves anti-epileptic medications along with physiotherapy, speech therapy, and occupational therapy to control seizures and improve functional outcomes. Dyke-Davidoff-Mason syndrome is a rare seizure disorder that must be differentiated from other conditions such as Sturge-Weber syndrome, linear nevus syndrome, Silver-Russell syndrome, Fishman syndrome, and Rasmussen's encephalitis. Neuroimaging, CT and MRI are the modalities of choice, and as they allow evaluation of cerebral hemiatrophy and associated bony changes, thereby helping to distinguish between congenital and acquired forms of Dyke-Davidoff-Mason syndrome. Early diagnosis is crucial, and treatment should focus on optimal seizures control along with domiciliary physiotherapy to enhance quality of life. Conclusion: Dyke-Davidoff-Mason syndrome is a rare and likely underdiagnosed condition with both congenital and acquired forms. It typically presents with contralateral hemiparesis or hemiplegia and various seizure types, most often managed with anti-seizure medication. Through surgery may be considered in selected cases. Radiological features such as cerebral hemiatrophy, calvarial thickening, and Park shift vary depending on the timing and severity of insult. Prognosis is variable but tends to be better when symptoms appear after 2 years of age, though many aspects of this disorder remains unclear. These are my references. Thank you.